This conference will now be recorded.
Your time starts.
Shall I start?
Yeah, please.
Hello, I'm Disha. I'm one of the doctors today. Am I speaking to Christina Williams?
Yeah, that's right.
Christina, could you just confirm your age with me?
Hello, doctor. I'm 53 years old.
All right, nice to meet you, Christina. How are you doing today?
Well, not really good, That's why I'm here actually.
Oh, I'm so sorry. Could I know more about it, please?
Yeah, sure, doctor. Actually, how do I put it? For the last, it's been months now that I've been having these bad hot flushes. I mean, at times I just wake up in a pool of sweat. It seems at the night, particularly if I've noticed that, and I don't know. Sometimes it just comes anytime. It's just any time that I start feeling very uncomfortable. I can't concentrate. It's been affecting everything I do recently.
Christina, that sounds really distressful. I'm sorry you have to go through this, but is it okay if I can ask you a couple of more questions? This will help me manage you better.
Yeah, sure, doctor. Yeah.
So, do you have you noticed any change in mood recently as well?
Yes, you can say so. I mean, I'm always very irritable and I don't know, I cannot concentrate.
All right. And are you working now, Christina?
Yeah, I'm a sales manager.
So is it affecting your work life as well?
Oh, you tell me about it. Badly. Yes. I have to keep, people stare at me when I start sweating like that. It's bad.
I'm so sorry to hear that, Christina. Sorry, but this might be a bit intrusive, however relevant. Are you sexually active?
Yes, yeah, kind of. Well, how do I put it now? It's become very painful of late, yeah. And I don't know. I don't feel like I think I've lost all interest, and it's I've started avoiding sex altogether, really.
Yes, understandable. So you said you stopped having periods since 6 months. How were your periods before that?
I think I was okay. I used to have regular ones before, but then for the last 6 months I haven't seen them. Before that, I think it was okay. It used to come down every month.
All right, all right. And are you up to date with your HPV testing?
I'm sorry, what is that?
Are you up to date with your smears?
Oh, yeah, smear. Yeah. I'm up to date with that, and I think the last one was normal. Yeah.
Okay. And are you visiting your GP for any other condition?
Nothing of that sort.
Any allergies?
No.
And have you ever undergone a surgery before?
Surgery? No.
Okay. Any family history of concerns such as breast cancer, ovarian cancer?
Cancers? No, not at all. No.
Okay. It's quite relevant to the treatment I'll be offering you. Sorry, I don't mean to scare you.
Okay.
Yes. And do you smoke, Christina?
Yeah, off late I've just cannot control. I've increased to almost 10 cigs per day.
Oh, I understand. Must be quite distressful, but have you ever thought about quitting that?
Yes, I used to try, but then this condition is not really helping me.
I know. However, you trying is a great thing. If you want, I can refer you to NHS Stop Smoking Services. They have benefited a lot of people in the past as well.
Okay, that sounds good. Okay.
Okay, I'll just give you their number. You can have a try if you'd like. All right, Christina, and how's the support at home? Who do you stay with?
I have my husband, and yeah, he's been very supportive, really, because I'm not really been in the best of my moods, but he's been very supportive. Yeah.
All right, that's great. I'm glad to hear that, Christina. All right, so I just want to discuss from your history, what I see is that this is something we go through in menopause women. Have you read about it before? What happens during menopause?
I know that you stop your periods. So I also thought that maybe, yeah, it's menopause now for me.
Yes, so Christina, you're right. The periods tend to stop, and our ovaries, which contain hormones and eggs, they tend to decrease. And so these symptoms do come up when the hormone production stops, like what you're facing. So this explains
Mhm.
why you have been recently having mood swings and difficulty during your sexual life as well. Am I
Okay.
clear? All right,
Mm-hmm.
so I'd like to tell you that there are a couple of options available for you. We have hormonal. We have the one thing, Christina, we talk about with everyone is lifestyle. It's more of a natural way with least side effects, and it really tends to improve a lot with regardless of your treatment with hormones or not. So lifestyle
Okay.
changes in the sense of stopping smoking and cutting down on caffeine, alcohol, increasing having a good diet and calcium, milk. I can refer you to a dietitian as well. For another
Mm-hmm.
thing, your night sweats, I know they're quite distressing as well. What we can do is we uh, recommend you wear some loose clothes, and so you can wear some light clothes at night as well and sleep in the AC. And so stuff like that. The other thing what I would like to talk about is hormonal replacement therapy. Have you heard about that?
Oh, yes, I actually read about that, and I was wondering that, if you could tell me about it, I would like to know about that.
Yes, absolutely, Christina. So a hormone replacement therapy would include now, it would have the estrogen hormone and the progesterone hormone. I'll be telling you about that as well. So we give this, and now it depends. You can take it either with a break or you can take it continuously. Um, but some women prefer to have it continuously because when taken continuously, you would not even have any bleeding episodes. There are some side effects, some mild ones, such as nausea, vomiting, which we will be giving you some anti-sickness and even some spotting in the first 3 months. However,
Mm-hmm.
spotting beyond 3 months would be concerning. So I would like you to come back and I will talk to you more about that in detail once we're done in a 3 month follow-up period. The other thing, HRT would also have seen that there is a high chance of having clots. I'm sorry, but anyone in your family had clots or you had clots before?
No, not that I know of, no.
Okay. All right. So there's a very minimal remote chance of you developing clots. And well, studies are still under the way, but even breast cancer is on the rise. But that would be more so if taken for a longer period of time. We would prefer that you stop taking HRT once your symptoms get better or maximum over 5 years. Am I being clear so far?
Yeah, so you say that there are some serious risks, like, I may land up with a cancer as well. So is there anything I can do to, reduce these risks? I mean, is there a way out that I take HRT and maybe reduce the risk?
Well, NHS for breast cancer per se, we can do the screening, breast cancer screening every 3 years by doing a mammogram as well. Other than that, what you can do is lifestyle medications. This risk is very remote though, so it cannot be predicted much.
Okay. Okay.
The benefit for this is that the symptoms will reduce. Also, for your sexual difficulty, I can offer you some estrogen cream and lubricants. It would ease out the pain as well.
Okay. Okay. And I was wondering about any other options other than HRT that may be there. I mean,
Absolutely.
you just said I can have clots and whatnot. So, I mean, I was wondering if there's anything else.
Absolutely, Christina. That's a very valid question. We do have some happy hormones we give, and the other thing would be herbal medication. However, herbal medication needs to be taken with a practitioner, registered practitioner. There's some safety issues about that and some concerns. So I can refer you there as well if you do want. Another thing is these happy hormones, they elevate your mood as well.
Okay.
You can consider them, and I will be writing back to your GP and handing over a patient information leaflet if you'd like to discuss more. It's got a lot of information over there.
Okay. Okay. And would I need any blood test? I mean, you just said that I have menopause. Would I need a blood test?
Well, a blood test, the
Okay.
symptoms.
Unfortunately, the time is up. Okay,
Yeah.
Yep. Yeah, so what do you think? You were good actually. So
Borderline.
what do you think, Disha? How was your session?
I thought I was borderline,
Mm-hmm. No, you were
but I,
good. You were good. Yes.
I
Time
answered all the
management.
questions.
No, you were really good. So I liked your approach. I don't know. I think your friends will be able to say Dr. Rabba is there, but I think you were good. You touched a lot of
Yeah,
points.
yeah, actually, this was a very exam standard station. So well done, both of you. I think, yeah, it was very, a role player as an exam standard. Dr. Shreya, she made the same. Yeah, yeah, I enjoyed actually, guys, the discussion between both of you. Dr. Disha, you are good, okay? You are fluent, which is a very good thing, and confident. Um, I like your approach to the patient. I would give you absolutely a good mark in the communication with patient, but we have faced the problem of time. Okay,
Mm.
so at the beginning, I felt like it's history taking a little bit of, um, need to be reduced. Okay, so manage the time in the history taking. That will be my advice. Other than this, I think that if you had 1 more minute, you would be able to continue.
Yes.
Sorry for the
Sure.
voice. Okay, but all the best in your exam. There is a chance of improvement, and you are already good. I think that's more than borderline.
Okay. Thank you. Thank you so much for giving me this opportunity to present.
You're welcome, dear, and all the best again with your exam. Prayers with you.
Thank you.
Okay, so sorry, yeah. Okay, so it was good. So we'll just quickly go through certain things that we need to touch for this station. And if you think that you would like to add something or have any questions, please do tell me. So what I've done here is I have given certain basic points in the 5 domains on which you will be tested. So all of us know that there are these 5 domains, and it's a favorite of our COG. The first one, that is the patient safety. So patient safety, we have applied, we have info gathering or information gathering, we have communication with patient, communication with colleagues, okay? So Dr. Disha was very good, very fluent, like Madam said. Okay, a few points maybe here and there which were missed, but otherwise, I think time management, like Ma'am said, try to keep it between 3 minutes to 4 minutes maximum. Okay, so because while I was noting, you were on your 5th minute plus when you started the management, such that you had 4 minutes left when you were introducing lifestyle changes, right? So I think that is the only place to work on, because in online examination the screen goes blank. You don't have any time to even complete or wrap up the station. It just goes blank. Okay, so try to keep an eye. The good thing about online stations is that you have a timer in front of you. All right, so when you see that the last 1 minute is coming on, please make sure to wrap it up, no matter where you are, no matter how many things you have missed. Okay, because wrapping up is always a good way to end the station. That kind of gives you a lot of marks. Okay, so coming to patient safety point, as I said, that the most important slide here for this station. So of course, patient identity confirmation, very nicely done. You have elicited whatever was her concern, why she is here to see you today. So yes, you could bring out all her questions, all her things in her mind, including the sexual problem. This was very important and very well done, whether there was any contraindication to hormone replacement therapy. Mostly you did ask questions about any clots, any cancer. So these are the few things that we need usually keep in mind, whether there's any migraine headache, any cardiac condition or heart problem, because these are contraindications to hormone replacement therapy. You cannot prescribe this. Apart from this, herbal medications, this was something I was expecting you to ask. Why? Because this role player here, if you would have asked, she would have told you she has already tried a herbal medication. Okay, so herbal medications are known to be reacting with other drugs. Okay, so sometimes the questions may be medical history becomes very important here, so you need to ask, okay, are you taking any other medications, which you did. So of course I had no medical issues here, so this part was ruled out, safely ruled out. But herbal medication, many people will come. In fact, this was a recall, and the role player had come with taking isoflavons. Okay, so herbal medications is an important part. Apart from this, allergy is a routine safety point. Everybody needs to ask. Smear was well covered. You had been very good with the risks. You had nicely divided into common risks and serious risks, and very nicely put. And this was wonderful. So you did say that you have to come back to me after 3 months, and if all goes well, then it has to be annually. And red flag symptoms, now this requires a little bit more of time. Okay, so you need to just tell the patient one line at the end that if you develop any cramp or cramp like pain in the leg, or maybe you find your sudden pain in the leg, swelling, or anything which can suggest a clot or maybe a stroke, one line about that may be touched, because if you are prescribing HRT. So please remember, cancer stations and any stations wherein the risk of DVT is there, please remember to touch on the red flag symptoms. Okay, so this is about patient safety. This was very nicely done. So communication with patients, their relatives, you have introduced, you had a lot of empathy. You did take out her expectations. She wanted to know about HRT or any alternative method. You did involve the patient in decision making. That was very nice. You have signposted. Okay, and you did take up from her, because she was very worried, embarrassed about in her work. So you did pick that up very nicely. Okay, so you have asked whether she did understand, so you've checked her understanding. And yes, we were moving towards a very nice plan. Actually, only 1 more minute time was required, and you did offer PIL. Okay, if not for this, you have offered for other things, but then this was a good step. And obviously contact is a part of communication with patients and relatives. Information gathering, I think you have done well, except for the fact, if you would have asked her about her height weight ratio. Her height weight ratio was 39. Okay, so you are going to give her HRT. So this is something which needed to be, at least to let your examiner know that you know. Okay, so this is the thing. So you have asked mostly why she is looking for a treatment because she's having very debilitating symptoms. You did elicit her, I think, everything you have done. Only thing you did not ask was the bladder bowel symptom. I would have liked it better if you had asked about the waterworks, because most of these patients may have some problem with frequency, urgency as well. Okay, you did ask about this quality of life, asked work, asked. You did ask about partner reaction. That was very nice. And this is what I was looking for. Have you taken any treatment so far? Okay, so this question, please keep in mind whenever you're approaching. This goes well with this kind of station as well as with stations wherein we are dealing with maternal medicine stations. So please ask what treatment has been taken so far. This and gynecology stations also, mostly they might have tried something or the other. Okay, so what kind of treatment you have taken, how long you have taken, whether it has helped you or not. Okay, last period was already given here. Smear you did ask. This was not so much relevant in this case. She's already 53. But yes, how sometimes we ask this if you have time is that, this gives you an idea whether you can go for HRT safely or not. Somebody who has taken OC pills will be happy to take HRT as well. Okay, so relevant medical history asked, very well asked, breast cancer. And as I said, body mass index was missing. And you did ask about social history, so that was okay, that was good in information gathering. So this is a very nice picture if you want to remember about what happens in a menopause. So mood swings you asked, sleep disorders, hot flashes, headaches, difficulty in concentrating, loss of libido, having joint pain, being irritable, etc. So this is a, if you would like to just remember, so coming to applied clinical knowledge, yes, very good knowledge you had. So this was very nicely done. Actually this role player had a question for any doctor who would skip the lifestyle changes. She had a question that, can I not do anything about this? So very well done to start with lifestyle changes. You did tell about all of these. So when well ventilated, cool clothes, cool room. So it was well done. And herbal medications could have been asked. Alternative therapy, one touch of alternative therapy, because she did give you a hint. She asked about what are my other options. So before you go to happy medications, that is if you're going towards antidepressants, it is better to just talk about alternate therapy, although you need to add this as well, that alternative or complementary therapy are not really, they are still lacking in evidence. Okay, they may help, so you may try, which you did say. Okay, so acupuncture or acupressure, we really don't know. You may try that, but there is no broad based evidence based on either of this. After that, you may try to go to the non-hormonal other medical treatments like anti-epileptics or clonidine. Mainly it can be for hot flushes, because antidepressants, as far as my knowledge goes, antidepressants are given for people who are suffering from depression. Okay, so if you are not clinically having any depression, it is usually not prescribed for menopausal symptoms. All right, and this will be the choice perhaps if you are, you cannot go for a HRT, if there's a contraindication for HRT also. You did not talk about the cognitive behavioral therapy. I was waiting for that. I was hoping that you could finish, because this would have been perfect. So the talking therapy is something, because somebody who is whose quality of life is hampered, who is really having a tough time in her sexual life, who is worried that the husband may desert her. So somebody like that is a very good candidate for a talking therapy. Okay, so we could have just touched the talking therapy and one line or 30 seconds on alternative and complementary therapies as well. Okay, HRT, it was very well approached. What I appreciate is that you did speak about, I think, the types. Okay, a little bit about the routes, because in the last exam, the role player had a question: will it be injection, will it be tablet? Okay, so please, when you are describing, so you see everything requires a lot of time. So try to finish off your history by 3.5, 4 minutes, so that you have a lot of time to speak about and explore what she wants to know. So she would like to know if it is easy to take. So if it is easy like a patch, if it is easy like a tablet. Okay, so your routes, your types, this is something you begin with. So you began very well. We are introducing two hormones. We may give it in form of tablets, you may have patches, something like that. Okay, then you move on to the benefits, which you did say that yes, it is going to relieve your symptoms. And if you have time, you may even touch on that it is, going to help you to prevent your bone from weakening, bones, bone pain, bones weakening, etc. Common side effect you have touched. Feeling sick is a better word rather than using the term nausea and vomiting. Okay, so that will go down well with the patient as well. And this is very much similar to the what we read in OC pills. So that is there. You did speak about irregular bleeding. The serious risks are clot, stroke, and breast cancer. So breast cancer, very well said that it is a very if you take it for a longer time, and of course you can add that once you stop, the risk eventually wanes off. So you did say that I would like you to stop once you are having some benefit. So that was a good thing. Apart from that, I asked you, is there something which can reduce the risk? So reducing risk, I asked, was actually, this is what was the question, whether there is anything that can reduce the risk of clot or maybe stroke, because I'm frightened. You told me that I can have a clot. So you may say that yes, maybe taking a patch can help you to reduce this particular risk, provided of course you are at high risk. This particular role player was not really at high risk of DVT as such. Okay, this needed to be touched. Okay, this was a very very important point, which in fact is a very favorite of examiners these days. So they do expect you to touch on contraception, because she is sexually active, and you do not know whether she's been using any contraception at all. If she's been using a contraception, you are supposed to touch, because we are giving HRT, and you're supposed to touch that. Okay, we will be continuing the thing for 1 year after your last menstrual period. It had only been 6 months for her, so we still had time, and you had to calculate and just say that this is how we deal with contraception here. So this would demand a referral to the contraception clinic also. Testosterone patch, usually if somebody comes with a loss of libido, this can be a very good option for her as well. And you did touch on this. So vaginal moisturizers and lubricants for dryness. You have also talked about estrogen locally, so that was very well done. So this is in all about HRT's knowledge. As regard as communication with colleague, well, here you have more or less, if you could have wrapped up, I think you would have perfectly done it. So, we of course keep the GP in the loop. You have to give her a support group. She is upset, so you'll have to give her a support group. You have to, this comes in when your HRT is not working, or if there's some problem with bleeding, then menopause specialist referral is coming only at that point of time. You have to refer to a psychologist for the CBT. And of course it depends on what kind of station you are getting. So suppose you get a station, I will come up with two more scenarios. Dr. Rabah has very beautifully placed. I'll just show you people two more scenarios. So one of them has a background of cancer. So if that is the station for you, then you have to make sure you're referring to oncology or their specialists. Contraception, like I said, a physician if the patient has some migraine or some heart disease or whatever. Mental health is very important, particularly if you think there is any problem with depression. Okay, so I believe this is all we have. Yeah, so this is all we have. So anybody has any questions that I may answer here? Or Disha, I think everything is clear.
Hello.
Clear, doctor. Thank you.
Yeah,
Hello.
okay. Yes, please tell me.
Excuse me,
Ma'am,
ma'am.
here
Can
BMI
you
is
hear?
high.
Yeah.
Hello.
Yes, I
So,
can hear you.
so before prescribing hormone replacement therapy, we need to
Mhm.
refer her to hematologist.
No, not. It is actually for the BMI. The major issue would be clot, right? Her main problem would be that she will be more at risk of a DVT. Okay. So herein you can take a call based on what is her, severity of her complaints. So if she is having very severe complaints, which is affecting her quality of life, you can go for a patch for her. And of course, along with that, you have to ask for reduction of weight and appropriate referral if you think that she is suffering from any comorbidities along with that. Okay, but if she has time, if you think that her symptoms can be relieved with for example vaginal estrogen, okay, her problem is only dryness down below, then if that is the situation, then you go for that, maybe testosterone patch, and you can ask her to reduce weight till such time she can reduce her risk of DVT. So that is the importance of having a obesity in the question.
Thank you.
Ma'am, excuse me, ma'am. Any role of
Please.
Tibolone, ma'am?
Yes, role of Tibolone can be mentioned. I have particularly not mentioned here because you have to, you can mention that and say that, yes, Tibolone is usually given, if you read the TOG or read the strategy, 1 year after the menopause, okay, or after 54 years of age. So in our case, this role player was 53. Okay, and so she was not a candidate because she was below 54 years. And the second point was she was only 6 months amenorrheic. Okay, so once it is more than 1 month, 1 year of amenorrhea, and we may shift to Tibolone. Even you can shift from HRT to Tibolone, no problem.
Thank you, ma'am.
Okay.
If patient has family history of breast cancer in that condition,
Yes,
can
so
you
that's
state
exactly your, I think Dr. Rabba has a very beautiful station. Just to see, like your question, for example, patient herself has a history or a family history of breast cancer. Herself has a history of breast cancer is a problem for us. Okay, because we all are aware herself or self history of breast cancer, it is definitely not good to give HRT. We cannot give that. So that is the time when clonidine and gabapentin comes in. Okay, so you may go for alternative for her, you may go for complementary for her.
if patient family history, mother or sister has
Family
breast
history of
cancer?
breast cancer, usually,
Yeah.
if it is self, it is a complete contraindication. Family history
Yeah.
is usually not a contraindication. But
Oh.
family history means you have to be at guard. So, it also depends on what kind of breast cancer she is having actually. So in her case, she has to accept that risk that I have a background risk and this may increase the risk of breast cancer. Even though it is a little bit, but I am maybe more at risk. Somebody who is, for example, BRCA gene carrier, okay, that person may be more at risk, of course. So that time HRT is, it should be a decision which should be multidisciplinary at that point of time. But self history of breast cancer is a complete contraindication.
Yes,
Okay.
yeah, yes,
Thank
Dr.
you.
Shreya, and
Yes.
I think that it's worth remembering that the NICE guideline in
Yes.
those people who are having breast cancer or high risk of breast cancer, okay, they advised that to go for the non-hormonal method and for the multidisciplinary team. So the referral will be very important safety point in here, okay, and if okay it is okay means that the MDT say that HRT is suitable for her, that will be taken in the lowest dose. Okay, so this is what the recommendations say regarding high risk of breast cancer with the HRT. Okay.
Okay, so if you would see this question, as I said, it's a very beautiful question. Somebody who has undergone hysterectomy, and the reason for hysterectomy was endometrial cancer. So if this happens, you can also get a station like this. So if this happens, you'll have to keep in mind this lady. It's a very. I will just show you. See, this is what your answer should include. It's a very beautiful note. So regarding history and examination, you need to counsel the patient. So again, the same question: why do you want HRT? Okay, how severe are your symptoms? What are the relevant medical history? Any family history of breast cancer, or maybe self history, for all you know. Body mass index, very very important. And of course, what stage of cancer it was, because later on, if you will read that our evidence is very limited and it is mostly for stage 1 endometrial cancer. So stage of cancer, if the patient is aware, okay, or if the patient is not aware, then I need to go through your notes. Okay, so this is the basic approach. Rest remains the same. And how are you going to address the issues is whether there is truly an indication for HRT. So that's why the question comes: how severe is the patient's problem? You have to elicit that. If she is truly in need of a hormone replacement therapy, you have to elicit that. Chalk out the benefits and risks of HRT, and this risk is actually individualized, and this individualization is, in your case, in part 3, it is very much on that spot. You have to find out from the patient itself. Okay, apart from this, so risk of occurrence of endometrial cancer, see, this is the line I was talking about: insufficient evidence to indicate that HRT increases recurrence, particularly if it is a stage 1 cancer when there is no residual disease. So usually this kind of a patient will tell you that, no, the doctors were very happy with my operation. They told me it was a very early stage and they told me that nothing is left. Okay, so if that is the thing, then this particular, you can easily say that it is actually insufficient evidence, but you may go for it if it is stage 1 cancer. Stromal sarcoma, this is the theoretical knowledge, they have no data. Okay, so what happens if the patient comes with a stromal sarcoma in the histopathology report? Then you have to go for the patient's preference and whether she is willing to take up that risk. You have to tell her that we don't know. Okay, what happens? And this, I think, we have discussed in details in the last one. So lifestyle, alternatives, complementary, and in this patient who has undergone a THPSO, estrogen only is safe. But then again, you have to balance the benefit and risks also. One more thing which I forgot to mention in the while we were discussing was regarding breast cancer. You can also mention that if it is before the age of 50 years, that the risk of breast cancer in HRT with before the age of 50 years is actually not higher than the background rate. Okay, but after the age of 50 years, it is a bit more than the background rate. So if the patient is a younger patient, you may actually give her this information. So I think, yeah, this is just another area of questions from menopause. So this lady was with a premature ovarian failure. So you may get a scenario where a couple comes, okay, and maybe the lady is having symptoms which are like hot flushes, and she's a younger lady, and you find that a high FSH is given. Okay, so this may also be one of the presentations with perimenopause or menopause with a premature ovarian failure. So this comes under the another module actually. So this may be another type of question. So these are the 2-3 types of questions which usually come. Off late menopause is coming. It did come in last May also, and it did come in November. So so this can be the 2-3 areas of questions. Okay. So I'd like to, okay. Who will be coming up with the next station? Yeah, Dr. Noha. Yes, yes, please.
Yes,
Do tell
hi.
me when you. I will be shifting and changing the, slide.
Okay.
Okay, so are you ready?
Yes, but the slides are not changing.
Yeah, I'll show you. I'll show you. I'll just come. Yeah, there.
Okay.
So I start your timer.
Okay.
Your time starts.
Okay. Hi, I'm Dr. Noah, one of the doctors in the clinic today. May I confirm your name and age, please?
Hello, doctor. I'm Patricia Luca, and I'm 23 years.
Okay. How do you want me to address you?
Patricia is fine.
Okay, Patricia. Patricia, I know from your GB letter that you had migrated recently to the UK and you are pregnant now. You are 12 weeks and you had
Yeah.
did some investigations.
Mm.
Am I right?
Yes, I
Okay.
had
Do you
some
know
blood
about?
tests.
Yes.
Yeah, I just had
Mhm.
some blood
Do
tests,
you
and
know
I
about it?
was told to come and meet you.
Okay. Do you know about the results?
No.
Okay, I will tell you about this. Okay, Patricia. First, I want to ask you some questions to know more about you, and then together we will put a management plan for your pregnancy. Is it okay with
Okay.
you?
Yeah, that's
Okay.
fine. Yeah.
Patricia, tell me, is it your first pregnancy?
No, I had a abortion before.
Uh-huh. Was it spontaneous?
No, I really didn't want the pregnancy that time. I was young in school.
Uh-huh. Okay. And is it a planned pregnancy, the current pregnancy?
Yeah, this one is a planned one. Yeah.
Okay. And how was your pregnancy until now?
Yeah, it's been okay. It's fine.
Okay. And um, Patricia, do you have any abnormal vaginal discharge?
No, not right now. No.
Okay. Do you have any abnormal ulcer?
Um, ulcer. But you mean sore? Did I have a sore?
Yes.
Yeah. Now that you tell me about it, yes, I did notice one, but it didn't bother me. It didn't hurt. It just went off.
Yes. When did you discover this?
I think that was a few weeks back.
Uh-huh. And did you get any treatment for this sore?
No, I didn't think much of it. It just went off. Just came and went off.
Okay. And is your who are you living with?
Yes, I have my boyfriend.
Mhm. Okay, sorry for asking these questions, Patricia, but it will help in your management plan. May I proceed?
Yes, surely.
Okay. Okay. Is there any abnormality in your sexual intercourse with your partner?
Abnormal? No.
No. Okay. Does your partner have any sore like that one you had?
No, not that I'm aware. No.
Okay. And are you using condoms during sex?
Yeah, occasionally.
Mm-hmm. Okay. Did you have any surgery before from your tummy or down below?
Not surgery, but I had that abortion.
Okay. Are you known for any disease? Do you visit your GP regularly for any known disease?
No.
Are you allergic to any medication,
No.
any food or substance?
No.
Do you smoke?
I used to smoke, but then now I'm pregnant, so I just gave it up.
Okay. Do you take alcohol?
No.
Any recreational drugs?
No.
Okay. Is there any family history of concern?
I'm sorry?
Is there any family history of concern of any disease?
Oh, no, no.
Okay. During the last month, do you feel down or depressed or loss of interest?
No, I've been okay. It's just stressful to move to a new country, you know.
Mhm. And during the last 2 weeks, do you feel nervous or you can't control your thinking?
No, nothing of that sort.
Okay, thank you for sharing this information with me, Patricia. Is there anything else you want to tell me about?
No, I would just like to know if something is wrong, why I have been sent here.
Okay, Patricia, I will tell you about the results of the tests you did. I want to confirm again your name and age, please, and your NHS number. Okay, Patricia. The results are coming back that you have an infection with a bacteria. We call it a Treponema pallidum. Okay.
Okay.
This bacteria is the one that caused you the sore, but it is
Okay.
still in your body. And
Okay.
actually, during the pregnancy, it can travel to your baby, and it can make a harm for the baby.
Oh my God.
Are you following with
Okay.
me?
Yeah. So I mean, you mean to say I have this infection right now also?
Yes, it is still you have this infection.
Okay. And how did I get this infection then? How did this happen?
This infection have many sources. It may be from the sexual intercourse, or
Okay.
it may be from sharing the same undergarment or the sex tools.
Okay.
Okay.
Okay. So I mean, you mean to say that my boyfriend also may have this?
He may have this, or he may get this infection from you.
Oh my God. So
Um,
how do I tell him all this now?
you
Okay,
can
is it just
bring
okay if I
him.
get myself treated and like he needn't know this?
Um, Actually, Patricia, no, because he may get this infection and it may harm him if he didn't know. But if he know, he can get the treatment and he will be cured from this infection.
Okay. Okay.
We can help you. You can bring him with you next time.
Okay. Oh yeah,
Okay.
that'll be good, I think. I don't think I can get it across to him.
Okay, we can tell him.
Okay. So you just said that it can travel to my baby. So like what happens now?
Yes. Actually, I will refer you to a gum clinic to check for blood investigations for any other diseases. And I will refer you to a fetal medicine unit. There, they will check your baby. They will see if the baby catch this infection or not, and they will follow up for the baby. Okay.
Okay.
They may do some investigations for the baby there.
Okay.
During your pregnancy, your care will be by an MD team, which is a team of specialized doctors, doctor for neurosurgery and doctor for consultant obstetrician.
Okay.
Okay, and a neonatologist and a specialized midwife and specialized nurse. Okay.
And I mean, is it treatable? This I mean, treatment is there?
Yes, there is a treatment with a single dose with penicillin.
Your time is up, Dr. Noah.
Okay. How is it?
Yes, so you would have needed more time. You have to work on your history. Yes, because I think we were 6 minutes, 7 minutes into, history. Yeah. And this particular lady had a lot of questions. Okay, so she was just waiting for you to ask. Okay, so
But I forgot to ask her about the number of sexual partners.
yes. So we'll there are 2-3 things which has to be addressed in the information gathering as well. But work on the history taking. Try to practice with the timer on, because this is a big. You're supposed to talk about what happens to the baby and what happens to her and what is the treatment. So we have a lot to go, because this lady has questions till her delivery. She will ask you even after delivery. Okay. So yeah, so it's a big one, and you never know what the role player is sitting with. She'll sit with some 11 questions for you. So try to practice more on your particular questions, the information gathering. That has to be sped up a bit. If you can do that, you will have around 5 minutes time to talk about treatment and management of the patient.
Okay.
Okay. Yeah. So it was a very nice try. You have a very patient way of speaking, so that is a very nice thing. Okay, so that the role player will be happy to talk to you, so don't worry, but you have to work on the speed that you take the questions. Okay.
Okay.
All right, so we will like to talk about what other things. Okay, a little brush up on the theory. I think 2 or 3 slides we have on about syphilis and pregnancy. So not much different from the what you already know. So of course it can be acquired anytime during pregnancy or at birth. Okay, and if the infection happens before 16 weeks, it is usually very rare. Okay, later on in the pregnancy it can affect. So as we were discussing already, that the baby may be affected, and neonatal death may happen, latent infection may happen. Untreated syphilis leads to a huge fetal loss. So these are basically theoretical questions, but if some role player can ask you, sometimes role player, what kind of questions she might have, you don't know. So sometimes they may simply ask that, what is the chance that I may lose this baby? Okay, so just for that, it is not that you need to learn up each and every number, no, but it is about just an idea about the approximate fetal loss. So what happens is that most of the neonates are asymptomatic at birth. If at all it is a neonatal syphilis, then it may manifest as rhinitis. There may be desquamative rash, extensive rashing, particularly in palms and soles. It affects the liver and spleen, so there may be jaundice, there may be splenomegaly, and there may be anemia, thrombocytopenia. This is a very common problem. Anemia and thrombocytopenia is why mostly you will find hydrops in such a baby. And clinical signs, if it is present at birth, then the mortality is very high. It is again 50% mortality for such a baby. So this is a risk to the fetus. As Dr. Noah said to the role player, that yes, we will be referring you very correctly to the fetal medicine unit. Why? Because they will be keeping you under some scans. So why we want to do the scans is because the everything that may happen to the baby comes out in the scan itself, and it has to be done by the specialists. It cannot be done by us. So what is the most common manifestation is actually the growth restriction. So it is almost always associated with reduced amniotic fluid volume. We are all aware of this. And that time fetal anatomy may be very difficult to examine. So this requires a specialist. Okay. Usually the baby who is affected by syphilis may present with severe fetal growth restriction at the beginning of the second trimester. Okay, so FGR, you can say when the role player asks you that, it may be like, what happens now? How can I know if my baby is affected? Okay, so what happens to my baby? So if it is what happens to my baby, you have to say that the baby tends to grow small. Okay, if the baby is affected, may not be up to the mark in terms of growth or weight. Okay, the fluid around may reduce. These are known risks. Apart from that, there may be some changes, some problems in the, in the brain, some problems in the bowel, and of course there may be fluid accumulation all around the baby. Okay, so use your non-medical terms in order to describe this, and usually you have to give one line about everything when you're trying to say how the baby is affected. Okay, so if you're trying to, please avoid the word hydrocephaly or hydrancephaly or microcephaly. No, you may say that there may be some problem with the growth of the head. Okay, the head may grow small, the head may grow big. Okay, so something like that, and these are very common and reactionary or inflammatory reactions to the infection more than the infection. Okay, so these are the changes. Apart, if you will remember from your knowledge which you already have, that cerebral calcifications is actually there for all. You can see it in toxoplasma, you can see it here. So it is not specific to syphilis. Apart from this, again, same goes for most congenital infections will be affecting the liver and spleen. So you will find hepatosplenomegaly, you will find ascites, you may have, this may happen because the virus is directly, or the bacteria is directly affecting the liver parenchyma. Okay, so altered liver functions if the baby is born, or you may find this in ultrasound as well. And non-immune hydrops. So there is also a station on non-immune hydrops. So please remember congenital infections as one of the very important causes of non-immune fetal hydrops. So apart from rubella, CMV, syphilis, so these are very common causes of non-immune hydrops. A little bit about this. So this is what it's like something you need to remember, that whenever you are given a case of syphilis or suspected syphilis, you have to refer that lady to sexual health service for follow-up and management. Please don't forget that even if the lady is pregnant now, she will require a long-term follow-up, and that is a patient safety point. So please remember that you have to mention sexual health service and long-term follow-up for this particular patient. Okay, partner notification, why the role player brought that up. She did say that I do not want my partner to know. Let it be that I get treated and let him not know. You cannot allow that. So that is why partner notification, very gently put, very sensitively handled, but you have to mention that. Same goes for HIV as well. So partner notification, please remember to mention. These are the buzzwords to pass. Okay, apart from this, whenever you are putting a patient to sexual health service, that is the gum clinic is no longer said, so better avoid and say sexual health clinic for ongoing management. Apart from that, you have to tell the patient why she got it. So maybe it was very nicely said, Dr. Noah, there can be many reasons. So that was very good, and not being judgmental that it is only transferred by sexually, it is a sexually shared disease, and that you get it only from multiple partners. Do not put it that way. So try to be non-judgmental when you are giving such a news to the patient. Okay, so this is the same approach for, I think, even HIV should be there. So again, partner notification should be discussed, it should be initiated, and there should be a look back period. So the look back period is actually what we know as contact tracing. So it is, we are trying to trace. So if somebody is, you think is of primary syphilis, you look back at 3 months. If you think that the patient has features of secondary syphilis, like maybe rash or some other systemic involvement, you look back to 2 years. Okay, in your case, this case, the role player had a sore, a painless ulcer. Okay, so this case only dealt with probably primary syphilis. She was otherwise fit and fine. So if that is so, it is only 3 months. Late syphilis is very difficult, and thankfully so far late syphilis has not come, but we should be aware. So late syphilis is very difficult to put a time on that. So you can look at any time between 2 years to even 10 years. Okay. So this is about how to do partner tracing. This is just a brush up of the treatment. I wanted Dr. Noah to finish the treatment because she did ask about allergy. That was a very good thing, because this is like one of the most important questions you can ask to put a tick on your pass, that one thing is the allergy, because you're going to give antibiotics. Okay. So the treatment is a very simple treatment, and this is what reassures the patient also, that it is very much treatable condition. Okay. So first and second trimester, you have to mention that there's an injection called penicillin, and it is given in your it is a intramuscular injection. In the third trimester, you have to increase it to 2 doses. So in the first and second trimester, in this case, the patient was a first trimester patient, so single dose. If it is a third trimester patient, you would require to repeat after 7 days. In case of late latent or cardiovascular or gummatous syphilis, then you have to go for 3 doses. So it will be 1, 8, and 15, or 3 doses, which has to be given. So usually our case scenarios are in early syphilis and pregnancy. If it comes in pregnancy, it will come in this slot or this category. Okay. So it was a very good question what she asked about how your pregnancy is. So we'll be discussing all the points, whatever she asked. Yes. Okay. So this is the last about the brush up. Please remember that, after the antibiotic, there's a possibility of a reaction, which is called the Zarisch-Herxheimer reaction. So this reaction can happen, and you have to tell your patient about this. Okay. So please remember to say that you may feel feverish, you may feel, have some headache, or may have some muscle pain, but it is okay. It goes off on its own. I would like you to stay hydrated. I would like you to take some paracetamol, and you should be fine. Okay. So this is, in case of primary syphilis, half of the patients may get this. In case of secondary, almost 3 out of 4 patients may get this. Okay. So please do not forget, wherever you're giving penicillin, please do not forget to mention, at least you don't have to mention such a big name, just mention that there may be a flu-like, reaction to the injection. Okay. And one line here is that some additive treatment may be required, like steroids, particularly if it is a systemic involvement, like neurosyphilis or cardiovascular involvement. But then you can read it from the BASH guideline, it is there. All the alternative therapies also are given. For example, you may have a situation where the patient may say, yes, I'm allergic to penicillin. Okay. If you have that station, then you may have to know the alternative treatment regimens as well. So whenever you get a station, you better know what are the things which can come in a station from that particular area. Okay. So talking about the domains. So again, the 5 domains. Please remember this most important slide. Okay. So first and foremost is patient identification done. Elicit concern, allergy, very, very important. Okay. Tell about the risk. Whatever risk you have to be honest about it. You do not dilute the risk and tell. Okay. This is the rule number 1 if you want to pass part 3, because they expect you to tell, no matter how little the risk, they will expect you to tell that. Okay. So please be honest about the risk. Safe sex is very important, and I was hoping that somebody would pick up this safe sex. Why? Because Dr. Noah did ask me about the role player, whether you use condoms or not. Very good question, because safe sex is something you have to advise to this lady, and it comes under patient safety. You cannot miss that. Why? Because syphilis is not, you don't develop immunity to that, right? So you treat it, it's only one-time treatment. So it comes back again, and yes, if the patient asks you that, can I get it again? Yes, you can get it again. So that is why the practice of safe sex is so important, and it comes under patient safety. Do not forget that. Okay. So ruling out other STI, very well done. She did ask any other vaginal discharge. Were you treated for anything else? Because usually, if the role player or the patient is of promiscuous nature, then you may have other multiple STIs also involved along with syphilis. Partner notification, contact tracing is a patient safety point. Reaction has to be mentioned. Follow up. Now this is something we have to learn by heart. That is, the follow-up of syphilis is a long follow-up, and usually we are doing some blood tests like VDRL. So the blood tests will be at 3 months of treatment, 6 months and 12 months, and they have to be negative. Until they are negative, you have to keep following her up. Okay, why? Because this can move on to late latent syphilis. This can move on to tertiary syphilis, so we need to be very, very aware that the thing is gone. Okay. Now, information gathering, this I would have liked it if a little more description was there. Like, you have to tell your examiner that you know the symptoms of primary syphilis and you know the symptoms of secondary syphilis. So you have to ask about any painless ulcer, any swollen glands down below, okay, any rash you noticed, any flu, okay. So these are any systemic involvement. You may ask about some eye problem or bone problem if you have time. Otherwise, I think it is more than enough to just mention rash and flu. You will get an idea whether the patient has a primary or a secondary by that. Partner, similar lesion, very well asked. It was asked any symptoms in the partner. Now this was a question which was missed, and this is an important question. How long have you been in a relationship or whatever, something like that, just to elicit whether this is a new partner or there has been a recent change in partner. Okay. Recent unprotected sexual intercourse is important because you are dealing with a patient who just had a sore and you have syphilis positive. So you would like to know if there has been unprotected intercourse recently. It was asked whether there was any STI treatment. Okay. Now this point is something I would like to emphasize on, and why this is important is because if you recollect our case here, our case was a migrant. She has come from Poland. Okay, and we did talk about the various ways in which syphilis can come. Okay, and one of the ways may be treatment outside. This role player did give hint. She did say, I had an abortion, I had I underwent treatment. So if you would have explored more, she would have come up with a history of a treatment outside, or perhaps a history of a blood transfusion outside. And mind you, blood transfusion is a very important source of syphilis also. Okay, so particularly if your question has something from outside UK, please remember to tell. It can be anything, it's not necessarily for syphilis and pregnancy. Please remember to tell this in any other station that you get. If you have anybody from outside UK, ask about any treatment taken, any blood transfusion taken. This blood transfusion is very important. Okay. Apart from that, this was asked, so please don't forget, if you have syphilis in pregnancy, don't forget to ask about the present pregnancy. So if the lady has booked, whether she is a late booker, for example, you may have had the recall question, in fact, from November was a 24-weeker. Okay, and she had come in with her booking, the booking bloods. So she was a late booker. So try to explore the reason of a late booker, because here you never know whether there may be a hidden agenda as well. Okay, so somebody with a syphilis may be not having a very good living condition. Okay, so maybe you have to explore a bit more about the late booking also. So whether if she is a 24 weeks, you have to also ask about the 20-week scan, because that will give you a fair idea about whether the baby is affected or not. Ask about the booking bloods if you already have them. Okay. Social is a routine question, of which this is very important. Please try to rule out if she is a drug user, injectable drug user, and as I said, a hidden agenda or a domestic violence. Ask about occupation. She may be a sex worker. Okay, so you have to ask, and about mental health also, because mental health is important. These patients may not be very happy about if they are in a poor living condition. Okay, so Okay, somebody asks that what do I say if the role player asks, I have the infection now, what to answer as no symptoms now? Yeah, so Amal, the thing is that here you have to say that your blood reports say, it was very nicely told by Dr. Noah, in fact, that you still have the infection in your blood. Very wonderfully said. So you can say that this is how it's a natural way the disease behaves. So you first begin with a sore, and that just goes off without doing much problem, and then it stays in your blood, and if we don't intervene, if we don't treat you on time, this can spread. And if it spreads, that time you may start having symptoms much later than from now. Okay, sometimes it may even become latent syphilis, so something where the latent stage can come, and you may know after 2 years that you had it. Okay, so this has to be told to the patient that even if you do not have any symptoms right now, you have it in your blood and it needs to be treated, because there is, without treatment, this will spread. Okay, so this is the should be your approach as such. I'm sorry. Yeah. So coming to communication with patients and relatives, so this is, I think, the important point here would be the recent migration. So please remember the recent migration, uh, these 3 questions. Okay, and this should be your questions for anybody who has migrated or settled in UK recently. If that thing is written in your question, please put in one point there, that so how are you settled? Are you well settled? Okay, so what about your job? Okay, do you feel supported? Would you like us to if we can help you in any way? Okay, so please, any recent migrant, one word about this will bring you the point of communications with patient. Signposting is important because, of course, of the nature of the station. You all know that this is a sexually transmitted infection. So sexual partners very gently explore the possibility of multiple partners, STI symptoms, treatments, etc. Okay, so if you are explaining to the patient about the risk, so as I said, Zarix Herxheimer has to be told what is the injection all about, what are the side effects. Please mention to the patient that she need not be worried about her confidentiality. Okay, so it is okay. It is okay if she tells you that. Fine. So confidentiality is more important in HIV rather than anything else. But from your attitude, the confidentiality should be, it is actually expected in every consultation, not only STI, but this is something that you need to keep in mind. Apart from that, a plan has to be said, and please do not forget a written information or a PIL at the end of your station. And clinic contact is very important, because these patients require long-term follow-up, and they will slip out of your safety loop if you do not give them a clinic contact, and you will not make it through the station if you don't give this at the end. Okay, so there are some points, please take a note, that if you these points cannot be missed. Okay, so clinic contact is very important, even more important than written information. Applied knowledge we have been discussing so far, so I won't take up much time here. So baby, we already know. Mother, you can just give a word that it can spread. If you don't treat it, it can cause permanent damage. It can spread to your bones, to your heart, to your brain, even your eyes. Okay, your pregnancy is a high risk pregnancy, so we'll put you under a consultant led care. You will require more visits. We will see that the fetal medicine unit people are doing more growth scans, more scans. We will have a delivery plan in place for you, and talk about breastfeeding. Why I wanted to mention this is this particular role player had some, I think, 9 or 10 questions with her, and her one of the questions was, will it be okay to breastfeed with syphilis? Okay, so please, you can only imagine how extensive this particular station can be. So she did ask about her delivery, whether I can deliver normally, and she did ask about breastfeeding. Okay, so please make sure that you don't have to go into details, just touch the points. Okay, treatment alternative is important in your applied knowledge, because of if there is any allergy that crops up, you'll have to mention about the alternative. So the alternative would be azithromycin or erythromycin in case of severe allergy to penicillin, but milder allergy can go for ceftriaxone. So somebody with a needle phobia may be given amoxicillin and probenecid. Okay, so it will depend on what question you have, or what the role player has in her cards. Okay. Communication with colleagues, simple ones we all know. So GP, consultant-led care, sexual health clinic refer, FMU refer, a special midwife for her, and this is important, particularly third trimester or somebody about to, you have to tell her that we will put the pediatrician or the neonatologist in the loop for your baby. So you need not worry. So this is, I think this is all. Yeah, this is all. So any question? Or did I speak so much, my God? So anybody, any doubt?
Dr. Shreya, only regarding the antibiotics, just wanted to know that the previous slide, I'm sorry, if you can just
Yeah,
show.
yes.
Yeah, regarding this azithromycin and erythromycin, still we can give, because according to
This
the
is
TOG, it's written that the ceftriaxone, and we can refer to the immunologist for desensitization.
yes, the idea is that if there is severe allergy, for example, ceftriaxone, as you know, is a cephalosporin. So this is very much like our penicillin group. So that is why ceftriaxone is only to be given if the patient has a mild allergy. For example, patient will say that I only had itching or I had redness or something like that. But if somebody had something as bad as anaphylaxis, as bad as respiratory distress, we cannot give any penicillin, to that patient at all. So yes, what you did mention, what we can do here, if somebody is there with a severe allergy, we can make a referral. So we can make a referral to an immunologist, take an opinion of the immunologist, but if the treatment is required for a severe penicillin allergy, you will have to go for, erythromycin group for that patient.
Okay. Okay, thank you
Yeah.
so much.
Okay, so fine, syphilis.
Thank you very
Okay.
much, Dr. Shreya, for the beautiful and wonderful feedback. And our next case will be with Dr. Intisar. She is next,
Okay.
and she's having exam in February, so all the best. We
Okay.
are praying. Dr.
Okay, so
Intisar, dear, are you ready?
Yes, ma'am. Thank you, ma'am.
okay, so if you're ready, I'll just put the question in front of you, set the timer. Dr. Intisar?
Yeah. Yes,
Yeah,
I'm
you're
here,
ready?
doctor.
Yeah, sure.
Yes,
Okay,
yes, ma'am.
okay, okay. Okay, so I put on your timer, please.
Shreya, please, could you please review the slideshow because it went off. Sorry.
Okay, you can start.
Okay. Hello, I am Dr. Abdul Qadir, one of the doctor in the clinic today. May I confirm your name and age, please?
Hello, doctor. I am Anna Stevens and I am 28 years.
Okay. It's okay to call you Anna.
Yeah, it's fine.
Okay, thank you, Anna. Nice to meet you today.
Nice to meet you, doctor.
I understand from your GP referral letter that you have certain concern or certain problem during your sexual act. Could you tell me more about your problem, please?
Yeah, actually, I just feel so, embarrassed to talk about this, but then, I just decided I needed help. I mean, I just got married, and after marriage, I've been so uncomfortable, every time with sexual intercourse, and then I don't know. There's been so much of burning down there, right? And after some time, I just feel I can't continue. You know what I mean?
Yeah, I'm really sorry for that. And please, everything you said here is totally confidential. Don't worry about that. Okay? And
Okay.
I will not give any information to anyone unless you permit me for that. Okay?
Mm-hmm.
So please, and I'd like to ask you a couple of questions to know more about you and about your condition, so that at the end of our discussion, we could reach a mutually agreed plan. Is that okay with you?
Yes, doctor. Fine.
Yeah. Before your marriage, you was sexually active, and
No, actually, I was a virgin. So I just, after I met, my husband, and then only after that I've been sexually active.
yeah, this difficulty in intercourse. Could you, I'm sorry, to describe exactly when it is at the start or when your husband is deep into you?
I think it's at the very beginning. There's no pain in my tummy as such, and I have been recently seeing that I feel very tensed. It's like a wall down there, and it starts burning, and it's just adding to the problem.
Yeah, is this accompanied by, for example, any abnormal discharge from down below or bleeding, for example?
Bleeding, no. Right now I don't have any discharge, but then I used to have a lot of thrush, in my teen years. But now it's fine.
Okay. Is this any problem with your waterworks or your bowel opening?
Yes, I actually did get treated for my waterwork infection, a few years back.
Okay. All right. But at the end, I can, you mean that penetration didn't happen till now? Full penetration didn't happen till now?
I just couldn't continue. Yes, I think in the very beginning we did manage, but after that I just can't continue because of the pain and the burning now.
Okay. Are you updated with your cervical screening?
Actually, I firstly I did not go for the 20 on my 25th year, but then now when they called me, I don't know, the nurse just said that it's abnormal down there, and that nothing can go in, and I couldn't get a smear done, and I was so afraid that time, so I just came off. So no, I never had a smear.
Do you have any medical condition you see your GP for or receive treatment for?
No.
Do you perform any surgery in your tummy or down below before?
No.
Are you allergic to any known medication or any materials?
No.
Do you smoke, Anne?
No, occasionally I used to smoke, but now it's just increased a bit.
Any alcohol or
No,
recreational drugs?
no.
Okay. Do you have any family history of concern?
No.
Okay, thank you for sharing this information with me. And coming to your concern about that pain and this difficulty upon intercourse, actually, from what you said to me, most probably this is a condition called vaginismus. Do you hear about that before?
No. I
Actually,
mean,
it's a
does this mean that my vagina is too small? Because the nurse, she was very particular. She said that it was just like it was blocked down there. Is it abnormal?
No, actually, this is not about by the size of your vagina. Actually, this is involuntary contractions of the muscles that surround your vagina. It is against your will, and which occur upon anything try to touch your vagina or touch your intimate area. I am
Okay.
clear so far?
Yeah.
So it is not about that you have small or narrow vagina. It is just a matter of tense muscles around your vagina. That is why
Okay.
when it is you have been told that you need an operation to fix it. Actually, any operation in that area will make the things more worse, because it will lead to formation of scarring that will make the things more worse for you.
Okay. So what do you suggest? I mean, will I never get a treatment for this then?
No, of course not. And there is a treatment for that, and it is successful in most of the instances. Be sure of that, and trust me, and me and my team will do our best in order to help you with your problem.
Okay.
Okay,
Thank
and
you.
I understand also from your GP referral letter that you have been on a mild depression 2 years ago, and
Yeah.
do you receive treatment for?
No, not right now. I just had it at that time, and I took some medicines at that time. I was giving pills.
Yeah, so it is successful treatment till now.
Yeah, I'm no longer on those pills, because you see, doctor, I'm trying to conceive also, and I just think that this thing won't let me conceive, because it's so difficult to have sex. So
But
I'm not on pills.
yeah, you're living now with your husband. Yeah,
Yes.
do you feel supported and safe there?
Yeah, actually he's been very understanding, but I'm just scared that if I continue doing this is not going to last for long.
No, of course we're going to after treatment, and we're going to arrange an appointment with our consultant together with your husband in order to clarify anything for him, so that he could understand well the condition and helping you in the treatment. Okay.
Okay. Okay.
Okay, so now coming to this condition, actually, it is really very beneficial for it that will be referred to a physiotherapist, which will help you to how to by certain programs of exercises to relax your vagina, and for anything that comes to touch your vagina or intimate area. And
Okay.
gradually by using of certain what we call vaginal trainers or dilators, that of different sizes, starting by the small size, increasing gradually, so that this will help you to accommodate with anything penetrating your vagina gradually. So but by the end you will feel totally relaxed and able to put this vaginal trainer successfully and with satisfaction.
Okay. And what about the pain, doctor? I'm having this bad burning down there. I mean, is it something bad?
No, no, not at all. But because there is some sort of friction occur, because there is some sort of resistance for penetration, this lead to some sort of uh, uh, um, um, like a bruises or mild, very mild bruises or laceration of the vagina lead to this burning pain. So that will be very beneficial to use certain water-based lubricants on that trainers or even during intercourse after finishing treatment. This will help that to avoid this burning pain totally.
Okay, your time is up. Just a minute.
This actually always my biggest problem about about time
It's
because I
it's
don't
not your
know.
problem. I think we all have faced this. It is the most common problem, fighting with time.
I
So
will. I'm sorry, ma'am. Just I think what is left is for the psychosexual counselor in
exactly,
order to
exactly.
talk to
We can
her
only help.
and
Yeah,
for.
yes.
Okay,
But you
sorry,
did
ma'am.
good.
Thank you.
I think all the role players' questions were answered, and you've dealt with it beautifully. So she is happy with you. So that should not be a problem. But try to, as I said, you can see the timer in front of you in this, okay? So when you're giving the exam, please start wrapping up. Speed up when you see the last minute in, okay? Please do this, because otherwise, it feels very bad and you don't get time. Once you are moving from one station to another within a span of 30 seconds, you have no time at all to feel bad or feel good, okay? So
Yes, ma'am.
yeah, your target should be, you can see the timer. That's a very good thing in online examinations. So try to, the moment it goes into 1.5 minutes, start wrapping up whatever you remember.
Yeah.
Even one line touching would be more than enough, okay?
Okay, ma'am. Thank you, ma'am. Thank you, Dr. Rabah, for this opportunity. Thank you.
Okay, uh so about female sexual dysfunction, there's this is a it has a recent talk article has also come in 2021. So please go through that, because this has come after, I think, quite some time, but it is again because of the talk article, this can come again. So female sexual dysfunctions can be varied. One of them is vulvodynia or vaginismus. Apart from that, there are other problems as well, which may come along with this kind of a station for you. So coming to what was important for this station, actually, it was very well done by Dr. Intisar. This station mainly requires you to be empathetic. And what is important, as with any case of vaginismus, vulvodynia, or female sexual dysfunction, um, as with any, for example, chronic pelvic pain, as with any of these stations, please rule out, as I said, domestic violence, any hidden agenda, any sexual abuse. This is the only safety point you have to keep in mind whenever you find a distressed woman. So a distressed woman, uh, or somebody with a preterm labor in antenatal cases. So please, take a note in your, whenever you are making a note before going into the exam, that what are the situations in which I should be thinking of a hidden agenda, because hidden agenda, the role player will not speak, will not make it evident. If you've gone through the videos of RCOG, there are very good ones on domestic violence where there is a bruise, or it is mentioned that the woman has a black eye. But all those things cannot come as long as you're having online examinations. Of course, the role player will not have anything of that sort. So you'll have to elicit and try to identify stations which may have hidden agendas, and one of them is vaginismus and vulvodynia. So here it is very important, as I said, the only important point here is, please screen for any physical abuse, any sexual abuse, or any domestic violence, okay? Now, another patient safety point was this, and this I cannot recollect whether Dr. Intisar mentioned, but there has to be some investigations to rule out other sexually transmitted infections also. She did ask questions about whether you're having any itching, any vaginal discharge. Very good. But yes, if you think that there is a trouble like thrush, you think there is a trouble like vaginal discharge, or you believe there's an STI, go for swabs to rule out STI. Okay, because this becomes important. Apart from that, allergy was well asked, and these are common points. Communication with patients, again, common points, nothing excellent. What I would say, Dr. Entasa did mention, please bring in your husband. So please, infertility and certain sexual dysfunctions require couple attendance. So please, try to rope in the partner, or the boyfriend or the husband has to come. And that is one of the important points of when you're trying to communicate it with the patient. Empathy is the major thing in your whole station. Your demeanor, your way of speaking should be very empathetic and not sympathetic. Do not sympathize with the lady, but please be very empathetic. Okay, information leaflet is important, because this is not a well-known fact. They may land up thinking that I am abnormal, I have some abnormality. So information leaflet and support group, because they would like to talk to like-minded people. Information gathering, nothing, I don't think much extra is there from what you already know. So this details of the pain, because she was talking of burning, so you may have to ask whether it is superficial or deep. It was well asked. Whether it has happened for the first time, or it is secondary to childbirth, for example, or secondary to some OT. So that has to be asked. Where is the location? What is the onset? Whether it is all the time, or what we know as provoked or unprovoked vulvodynia. Whether it is only in the vestibular area, whether it is generalized. So this has to be elicited from the history itself. Whether any associated symptoms are there which may suggest, for example, IBS, or irritable bowel syndrome, or inflammatory bowel disease. Because we all know that these are all interlinked. So anything with endometriosis, for example, may also come with other pain disorders. So try to rule out just in one line whether any trouble with waterworks or bowel or anything. This I was expecting to be asked, but it was only family history of concern, I think she asked. But it would be prudent to ask about skin disease. So just one line about, do you have any known skin condition, or in the family anybody has any skin condition? We are talking about lichen planus and lichen sclerosis here. So just one liner about one pathology, dermatological condition. Other sexual dysfunctions, whether they are associated with this or not. For example, do you feel dry below? Do you have any lack of desire, lack of orgasm, lack of arousal? Okay. And vaginismus, which was the case here. So she did say that it felt as if I'm tensing up. So this was a case of vaginismus with vulvodynia, but there may be a mixture of something else also. Okay. So other sexual dysfunction actually requires counseling. So in any case, you will go for that management. So this is just extra point. That's all. Mental health is very important, because all these situations can make the patient very depressed. So mental health condition has to be asked. It was asked here. And try to rule out any other thing, as we already mentioned, STI. I was not asked about the painful periods in this case. So this is important. As I said, endometriosis or any PID or any other chronic pelvic pain. This lady, okay, she was recently married, never had an obs history. But if there is some multipara or somebody with an obs history, please try to gently and sensitively ask about traumatic birth, because traumatic birth should not be asked on face. The role player doesn't take it very kindly. So be very gentle when you are trying to relive something which is traumatic. Okay. And about medical, yes, this, because we all know that thyroid conditions, sugar may cause vulval itching or some other problem. So just a routine word about medical. Social becomes very important here, as we already did mention. This I have not mentioned. So if you have any indicator in your case, like some area which is known for having FGM, or some particular, the lady is coming from an area which is known to have the practice of FGM, please try to explore that area as well, because a case of vulvodynia may be actually secondary to FGM also. So you never know if this is a station of FGM. for you. Okay, so domestic violence, sexual abuse, FGM, partner reaction, all comes under the same. It is all in the same line. Coming to your applied knowledge, well, I think more or less not much examination is required. Okay, about examination, I would like to add here, for those who are going in for exam in February, online examination, clearly RCOG has mentioned, do not ask for examination. Okay, so you will also have a preamble before you go to the examination, and you will have the they will give you the guidance that don't ask for examination, because this role playing is purely on video conferencing, and they expect you to do this on video conferencing. Okay, so what you may mention, for example, in this case, you would like to see if there is any vulval pathology, right? So what can you say? So you can say that because of the nature of today's interview, it's a video conference, I'm sorry, I will not be able to examine you, but yes, you will require an examination eventually. Do not worry, we will try to be as gentle as possible, but we need to see if something is wrong down below. Okay, if your GP has already done the examination, then no need to repeat it anymore. Okay, so please remember this about examination. In this case, if at all you are asked about examination, it will be to rule out any obvious pathology and to rule out any tender points, and you may go for a Q-tip testing for vulvodynia. Okay, neurological problem, if the patient has any history, then you may have to explore neurological examination also in general examination. Okay, apart from this STI screen we have mentioned, and this will be from history. So if you have any history suggestive of iron deficiency anemia causing vulval itching, you may go for ferritin. If you think that this is a case of premature ovarian failure, or this is a case of perimenopause with vaginal dryness, you may think of FSH, you may think of TFT. So these are all coming from your history. Apart from this, now I have given two slides here, just like one for vulvodynia, one will be for vaginismus. So if this lady had a burning sensation, so you can just go through, both are overlapping. So you may choose to tell it one at a time, or you may choose to mix it also. Okay, so you may just start that maybe for your burning, we can help you. This was very well said. It will be a multidisciplinary team. So you can talk about lifestyle changes like loose fitting clothes, gel packs, avoid any perfumed soaps, avoid any bubble bath, use a donut cushion if there is a generalized vulvodynia or vestibular vulvodynia. Okay, so this will depend on what the patient tells you. Apart from that, lubricant was mentioned. Please do mention about anesthetic also, that if we may give you some numbing agent which may really help you there. Talking therapy is very, very essential. If it is possible, I would rather ask you to bring the talking therapy to the very beginning. So try to mention that, because this gives you point. So try to mention the talking therapy at the very beginning, or psychosexual counseling. This will involve both the couple. Pain relief can be advised for a vulvodynia in form of antidepressants, anti-epileptics. You can say there are tablets for this. And as you have already very well mentioned, very beautifully mentioned about vaginal trainers, physiotherapy, there may be other electrical therapies as well, like TENS. Surgery is not recommended, like very correctly said. And the pain may come back even after you do. Not only the scar tissue, if it is truly vulvodynia, it can come back again, even if you remove or do vestibulectomy for as such. Vaginismus, again, these are same, so I'm not repeating, this is same. So relaxation technique, these are just words, all theoretical knowledge, but you may just say relaxation technique. Vaginal trainers already mentioned. Okay, and surgery not to be done before anything else. So vulvodynia and vaginismus, if both come together, please try to mention this about vaginismus first. Okay, after that, once and relieving of the pain, of course, otherwise she will not be able to even attempt vaginal trainers. Okay, so this has to go hand in hand if your patient has both the things with her. So I think this was about management. About colleagues, we all know whom do we call? We call everybody. So we call the psychiatrist, the psychologist, we send her to the pain specialist, we send her to the physiotherapist, sexual health specialist. Now after this, it will be depending on your question. Okay, if you find any organic cause, then you refer to the appropriate specialist. For example, if you think that there is I'm sorry, this is a typing error. I mean to say lichen planus and lichen sclerosis or IBS or endometriosis, whatever. And fertility specialist, because this lady is looking for having a child. So you just have to say that no, once we can sort this out, and we really want to, this is very much treatable, and I'm sure you'll be fine. So once there's nothing wrong with you. For this, you are not infertile. Okay, so we will try, and once you are comfortable with your sexual life, there is no reason why you may not conceive. Okay, now yes, even after you're comfortable with your sexual life, and even after attempting for a year or so, if you're still unable to conceive, we may think of further investigations. We may think of sending you to a fertility specialist as well. Okay, so these all come, actually, you see, whatever I'm saying will take time. So try to, again, I would say, try to manage your history within 4 minutes. 4 minutes is also too much. In fact, 3.5. Okay. So this is about, I think, yeah, that's all. So anybody, any questions? Okay, so no questions. Okay. Dr. Rabba, would you like to add something? Dr. Rabba is there?
Yeah, I'm here just
I thought
joining
I've
from
been
my phone.
speaking so much that I don't know, I lost you.
No, dear, it's all valuable information. Actually, you make it very hard for me to add anything. This was, yeah, that was very organized and beautifully explained. The only thing that I can share with you guys that for the cases of vulvodynia, they tend to present in the exam as age, regarding the age. So it will be like older women. They have the problem of the vulvodynia, like pain in the vulva. It could be provoked or non-provoked, and this is what we need to ask about. Provoked means that when she attempts sex, okay, so she had dyspareunia, she had a problem, okay, pain during sex, and that will provoke the vulval pain that is unexplained. Okay, so this is for the vulvodynia. Sometimes it can present as a case of chronic pelvic pain, but instead of chronic pelvic pain, it's a chronic vulval pain. So the vulval pain is there all the time, whether the lady is having sex or not. Okay, and this will be managed like the chronic pelvic pain. So we need to manage to exclude any physical causes. Okay, and then we will manage as talking therapy. That's very important. Okay, the CBT support group, trying to find out if there is any problem like domestic violence or sexual abuse that could cause that. Okay, and then we can talk about things like painkiller or gabapentin or something like adjuvant pain management. Okay, referral to vulva clinic. Okay, I think it would be wise in cases of vulvodynia if you're not already there. So this can be a little bit different in the presentation from the case of vaginismus, because vaginismus in the exam has actually presented with so many different scenarios, and they all are real exam questions. One is one lady that she never had sex before. Okay, one lady that she had sex but she had difficulty with the sex. Okay, and she presented with infertility, like our case here. One case that she had developed the vaginismus or the problem of dyspareunia, to be exact, after sexual abuse, okay, or after some event that brought back the old memories to her, like termination of pregnancy. And we have the cases of dyspareunia, which is pain during sex after childbirth. We have also two cases for that. One, she has dyspareunia because also the traumatic birth, okay, affected her. Another one, Actually, it was because of vaginal dryness, okay, after delivery and with breastfeeding. Okay, so this one as well presented in 2019, I think, November, fourth day in the exam. So different cases of the vulval conditions, dyspareunia, whether it's superficial or deep, cases of vaginismus, okay, with attempting sex or never had sex before because of she is afraid at all and she is avoiding at all having a relationship. Vulvodynia in, as a form of chronic vulval pain, okay, and also this came as provoked or non-provoked. So actually the TUG article that has been released recently is very important, as well as the TUG article before in 2014. So if you're preparing for Part 3 exam, those two TUG articles are very important, okay, and be ready for any question that can come from this psychosexual problem. Thank you very much. This is what I need to say.
Okay. The last case we have a preoperative gynae list. Who would be doing this station?
I think that was Dr. Amal. He is already ready to present. Otherwise,
Okay.
we can, any volunteers, we can ask for volunteers.
So anybody wants to do this?
Ma'am, shall I, ma'am? Okay,
Yes,
somebody else.
please, surely. Who is this? Uh,
Hello.
Hello. Yes, please.
Yeah, I'm Sapna, and I think
Yes.
Dr. Manikam has also asked for that.
Please continue. You're going to examine.
No, it's like either ways. Last time I had a chance, that's why I was not opting. If you would like.
Willing, you can continue.
Shall I?
No worries.
All right. Thank you.
You can have.
All right.
Okay. So yeah. I'm sorry. Yeah. Okay, so before we start, the preoperative gynae list has come again. This time, what they do usually is that they will give some 3-4 rooms, and you are expected to only speak about each room, what you think, what tests should be done, and if you think that it is appropriate to take it up for OT, and whether there is any prioritization in that particular list. So usually this is how the stations are coming. So I will be showing you the question, and then after that you may speak at will, because there will be no questions from the examiner's side other than prioritizing. So usually you may be needed to be prompted, but other than that there is no other questions here. So it is what you think about each room and what you want to plan for each room. Okay. Okay, I will just share the question. Start there. Okay. There is one more page, so I will start the timer and you read and let me know.
Okay, ma'am. Next page, ma'am.
You can start.
Hello, I'm Dr. Sapna, one of the candidates for examination today, and I've read the scenario and I'm ready to start the gynec preoperative list prioritization.
Yes, you have 4 rooms here. Please go room wise and let me know about the prioritization at the end of the 4 rooms.
All right, ma'am. So the first room is a 32-year-old para 0 plus 2 with LP 6 weeks ago, now with PV bleeding and a scan with empty uterus. She's planned for DNC. So in this case, regarding the appropriateness of the case, I would like to reconsider the appropriateness because the scan already shows that there is empty uterus and it looks like a complete abortion. So DNC is not required in this case, and she is RH negative. So consideration for anti-D has to be taken. Regarding because of reconsidering the appropriateness of the procedure, so the venue need not be mentioned, and we have to see that whether previous scan was showing intrauterine pregnancy and then it had bleeding or not. Otherwise, we have to consider the diagnosis of a pregnancy of unknown location and further investigate regarding this in the form of further testing like in the beta HCG, and she has to keep on follow up. There could be possibility that it could be a complete miscarriage or a ectopic pregnancy or yeah, and she should be followed like a pregnancy of unknown location where with beta HCG after 48 hours and further scans accordingly. The second case is a 18-year-old lady with a large pelvic mass, likely ovarian cyst, and she's posted for laparoscopic oophorectomy. Here in this case, I would like to know the nature of the mass, whether it is a complex mass or a simple mass, or the size of the mass also has to be, and the ultrasound characteristics of the mass has to be noted. And if it is a complex mass, further tumor markers like LDH, alpha fetoprotein, and HCG has to be done. And if it's a simple one, depending upon the size of the cyst, whether it's already mentioned this large mass, whether cystectomy can be done or not, that is a consideration. And it could be endometriosis also. The CA125 is in a premenopausal sense, this cannot be taken as significant. And she needs to be seen by a multidisciplinary team also. So further, she has to be evaluated with tumor markers and higher imaging modalities like a CT scan. And the third in question is 37-year-old Paris lady with a recent termination of pregnancy, and she is posted for laparoscopic sterilization. At the background, she has previous history of DVT and subacute bacterial endocarditis, and her BMI is 39, which makes her a very high risk candidate for surgery. We have to explore whether other options has been discussed with her. Other long-acting reversible contraceptives has been discussed, and the background of her high BMI as well as the high risk factors. And if at all she is planned for a laparoscopic sterilization after knowing the risks and benefits, and already the alternatives have been spoken to, and she has resorted to laparoscopic sterilization, then this special considerations need to be on account of her high BMI. The laparoscopic entry techniques has to be the Palmer's point entry and the open technique has to be thought of. And again, she has to be the preoperative consultation from the cardiologist and anesthetist has to be obtained, and we have to get an get the history. When was this termination of pregnancy, and when was this last episode of this DVT and the bacterial endocarditis? Because with the recent termination of pregnancy, I would also want to know what were the mode of previous deliveries, whether it was cesarean section, but because that would also add up to the risk of the operation. Regarding the fourth case, this is a fibroid uterus with menorrhagia and hemoglobin 8.1. She is planned for myomectomy, and she is a Jehovah's Witness. Here I would like to see if again other alternatives has been treatment has been taken, and whether blood transfusions since she's a Jehovah's Witness, whether advanced directive is there, and has she been told that at times blood transfusion may be the only life-saving measure, and she might change the reconsider the decision for blood transfusion at any point of time. And whether the discussion about hysterectomy is also to be taken place, because myomectomy can also lead to may result in blood loss, and hysterectomy may need to be resorted to. Optimization of the hemoglobin before the surgery would be a better option with pre-treatment with if at all she is planning for surgery, then pre-treatment with GnRH analogs and correcting her anemia before going for a surgery would be a better option. In all these cases, I would like to have a note of the patient's allergy, the allergies, DVT risk assessments, as well as pregnancy tests in room number 2 as well as room number 4 especially. And if it was a remote termination of pregnancy, then UPT is also required in room number 3 also. According to the urgency of the procedure, room number 1, a DNC is is not required, not appropriate at this point of time. Room number 2, it is a it's a urgent procedure, but she needs further evaluation. And regarding room number 3, it is non-urgent, routine procedure. And room number 4, it can be done after correction of hemoglobin.
Yeah, your time just finished.
Thank you for your time.
Okay, thank you very much. Okay, so I think she covered almost everything in the rooms. Anybody would like to add anything?
Hello. Hello.
Anyone has any comment on the IVF pregnancy in the first room?
This patient is increased risk of ectopic pregnancy in view of IVF pregnancy. So beta HCG
Exactly
should.
so. So the IVF, yes, one is it is at very high risk of ectopic pregnancy. So we did talk about the differential diagnosis about being complete miscarriage or ectopic. Anything else comes in your mind when you have a 6 weeks ago pain abdomen IVF?
Molar pregnancy.
The OHSS also, it could be
Yes,
OHSS.
OHSS. So yes, we should keep in mind about OHSS. Yes, molar pregnancy always comes probably even after a termination of pregnancy, maybe. Yes, not wrong at all to have a differential diagnosis. But I think because IVF is mentioned, we would like to also keep OHSS somewhere in mind. Although this is not a classic presentation of OHSS, but then when pain is there, it is IVF, it's only 6 weeks, so it is better to also keep OHSS in mind as well. Okay, and anything about somebody already who has a history of DVT, and if like Dr. Sapna said very correctly, after exploring all other options, if she still wants laparoscopic sterilization, we can go ahead with cardiologist opinion, very correctly said. And what else do you think we should tell her given her high BMI and already she had a DVT? So what
Breaking
should have been?
thromboprophylaxis.
Yes, so we should have mentioned a bit about thromboprophylaxis as well in this room. So this is something to be kept in mind, very correctly said, because whenever you have a high BMI or a low BMI, and you will see that most of the laparoscopies usually will have extremes of BMI in their questions. Okay, so you see this one wanted a laparoscopic oophorectomy. She is BMI 18. So this also I would suggest that try to mention Hassan's and Palmer's point in both. Okay, so because too thin and too fat will be a problem for a laparoscopic sterilization or any laparoscopic per se. So a bit more extensive words Dr. Sapna did mention about other tumor markers, very well said. We have to just mention about what tumor markers we are talking about, so this would require more evaluation before going ahead. So I think it's a very beautifully written answer list here. So we can just quickly go through what we just discussed. So yes, likely ectopic pregnancy because of the empty uterus, and because we are not told about any urine pregnancy test or any beta hcg, so we would like to know about a UPT or whether at all pregnancy is there. So that is number one, we would like to know. Secondly, we would like to know the urgency, because I don't know anything about the condition, the hemodynamic stability of this patient. So if she is not stable, I would have to resuscitate with fluids. So my differential diagnosis would be ectopic, complete miscarriage already there, and OHSS also. And if somebody wants to put in other causes of bleeding in early pregnancy, I think that is not wrong also. So it can be other causes also, even remotely molar pregnancy, but that is not wrong at all. So as long as you mention all this, I think it requires assessment. This is the answer. So no, we will defer the DNC, very correctly said. It is not appropriate to go ahead with DNC right now. Before that, we have to assess what are we dealing with. So one urine pregnancy test, trying to manage it like a pregnancy of unknown location if it is coming as positive, or if it is not, then keeping in mind the possibility of OHSS, and to clarify what is my diagnosis in the first place. If the patient is dehydrated, which may happen in OHSS, then I will have to rehydrate. If she has lost a lot of blood, then rehydration. What else do we want? We would like to see her hemoglobin levels, so a full blood count. Keep some blood in hand. Also try to check her kidney functions, because that becomes important in any acute abdomen, any bleeding, anybody coming with bleeding PV. So if the patient is shocked, then we have to completely the management changes. That is, everything becomes urgent, all of this. Okay. So if we think it is ectopic, UPT comes as positive, and probably there's tenderness on one side, and if we think that it is ruptured ectopic, for example, then immediate transfer to theater for laparotomy. So all these answers will depend on what is your likely diagnosis. So if you can answer very in an organized way, you can start that if it is ectopic pregnancy, after resuscitation, I may consider to take to laparotomy and salpingectomy. Otherwise, patient is stable, I still think it is ectopic pregnancy, then we have to go for a scan and manage accordingly. It can be elective management also of ectopic pregnancy. If it is OHSS, again fluids is the answer, and apart from that we will have to go in the line of OHSS management and see if there is, because this is an IVF pregnancy. If we want to go ahead as a complete miscarriage also, if you do mention that, then you can actually say that if we have ruled out everything else, then or there was a previous ultrasound showing a live fetus, then it must be a case of complete abortion, no need of a DNC in such a situation. So this will depend on what is your diagnosis. So a better approach for this room would be to tell the examiner that these are the differential diagnoses that I think, and these are the investigations which should be appropriate to come to a diagnosis. Once I have the diagnosis, then the management plan will go accordingly. So this is for room number 1. Room number 2, on the other hand, is that we all agree to this, that it is a large mass, and very correctly put is that we need to know the nature of the mass. So very correctly put is, what is that? Is it complex? Is it simple? Is it at all an ovarian mass? Okay. So what kind of investigation would give me a better idea is the MRI. So I would like a scan by a specialist, preferably one MRI, to understand the nature of the mass. It may be CT scan, but MRI gives you more better idea about if there is a doubt in the benign or malignant, or you have a doubt itself as to where it is coming from. Okay. Apart from that, I would like to assess her. She's an 18-year-old, so I would like to assess below 40. I can go for and mention all the tumor markers that can be mentioned. And yes, this could have just added to the marks, that whether the patient has from her history any red flag, or in her case sheets, I would like to see whether there is any evidence that it may be a malignancy at all. Okay. So this case needs to be looked after by an MDT for sure, and only after the MDT we will have to decide on our line of management. So definitely this is not a case for laparoscopic oophorectomy right now. So if it is low risk, we can consider plain cystectomy, no problem. If it is high risk, then based on the MDT discussion, we will have to see what kind of operation they feel appropriate, whether it is laparotomy or whether they feel laparoscopy is okay. So it will all depend on our risk of malignancy. So depending on that, and we have to refer not only MDT, somebody with a interest in oncology must also be present in this MDT in order to take a decision. So this patient is not requiring OT right now. She is not in the OT list right now. She needs to be evaluated again. Apart from this, as I already mentioned, BMI is low. So please consider alternative methods. This you have to mention in anybody, just check the BMI, too low, too high. Please mention these two. Okay. Room 3 correctly said cardiac opinion. If the what she has told, I think, is much better than what is written here, because please add here that we have discussed other methods with her, including vasectomy. Now that I would suggest that please add that to your answer also. Apart from long acting methods, wherever the woman is more at physical harm because of a procedure, it is better to suggest a vasectomy of the partner if the partner is willing. Okay, particularly somebody of a cardiac disease or so. So after having said that, if the woman still chooses on to have sterilization, no problem. Why this is the operation of choices? Because she is multi-para. Okay, and she wants this, and she's already had I think a DVT. This lady has a DVT also. So obese patient, so hormonal contraceptions are difficult for her. So that is why I would say that laparoscopic sterilization, if she's choosing, there is no harm in it. Okay, so if she chooses that, we would need a cardiological opinion. Why? Because we need to see what is the status of her cardiac function right now. So one echocardiogram is very much essential before she goes into operation theater. Prophylactic antibiotics now, as we know that usually somebody with a subacute bacterial endocarditis may not require prophylactic antibiotics for all procedures, but here the patient had a recent termination of pregnancy that only adds to her risk, and that's why prophylactic antibiotics should be considered. Okay, very correctly put that previous termination of pregnancy also needs, the notes needs to be checked. Why? Because what was the nature, whether we are missing any pregnancy, whether it was a proven intrauterine pregnancy. So these things have to be also checked. Appropriate thromboprophylaxis needs to be mentioned because she already had a DVT and this is going to be a laparoscopic surgery. She will require thromboprophylaxis given her BMI as well. And again, for her BMI, entry techniques needs to be mentioned. Room 4, again, room 4, recent hemoglobin, whether the 8.1 is a recent one or it has improved now. Already this has been mentioned and correctly said. So it can, this patient should not be hurried. Better is to correct her anemia and then take her for myomectomy. So correction can be in form of iron, it can be oral or parenteral. GnRH analog preoperatively to that may even help us change the route or mode of incision. Advanced directive has to be checked. Cell salvage facilities have to be checked. And this operation has to be done in a place where every specialist is available. Counseling, very correctly said, regarding hysterectomy. Of course, if she has completed her family, then hysterectomy should be told to her that you may land up in hysterectomy even after myomectomy. And the operation should be done by somebody senior. And there has to be an in-house hematologist. The person has to be there for the operation. So this goes, I think, in lines of any Jehovah Witness case that you may have, be it pregnancy, be it hysterectomy, be it myomectomy. Priority wise, we have given room number 1 as the first priority because it may be ectopic. Okay, even OHSS is dangerous if it is so. Room number 3 is the next priority. The reason being, okay, I agree completely that this is a elective operation, but this priority is because of the high risk, because she's already had a DVT and she's a cardiac patient. There is no other reason of putting this as a priority. Room number 2 is requiring, the ovarian cyst requires a lot of evaluation. So that is there, and this can wait if she's not bleeding at present. And even if she is bleeding, we may go for medical management, GnRH analog to stop the bleeding, correct the anemia, and wait. Myomectomy is never the answer to acute bleeding. So that is why this can wait. And she, in fact, she will benefit from having a good hemoglobin of 11 before having her operation at all. So that is why this room is not in question. So apart from this, this is how we would like to put the priority as there.
Thank you, Dr. Shreya. Thank you very much for your presentation. I just would like to add something, if you don't mind.
Yeah, surely, ma'am. I'm
Okay,
waiting for your feedback also.
No, actually you did great, but I would like you to go to the first page of the gynecology list. There's something I would like to explain to my dear friends.
Yeah.
Okay, so guys, as we know, this is a pre-operative. Okay, you are sitting with your consultant. This is the introduction that you will have in the exam, that you are sitting with your consultant in the pre-op, discussing what list that you have today. Okay, and here the examiner asks you, okay, and the mark will be given to appropriate procedure, operation or others, okay, for this particular patient, if this procedure is appropriate or not, venue of proposed treatment, if this is going to be managed outpatient, day unit or inpatient, special need, okay, for any of the cases, Like, for example, the patient with Jehovah's Witness, okay, so we will make sure that there is a Testosterone Patch, okay, in the operation room. And then he will ask you about the priority. And here, the priority, actually, he want to ask you about which one you will take first. And maybe the examiner will ask you this in the same words, which one you'd like to take first. Okay, so this is a patient that's scheduled already for operation, and this is different from when we have a case like for consent, and the examiner is asking you about this particular case. In this case, the examiner will ask you about information, what things that you would like to know about this case, and in here you will need to discuss everything, okay, in details. So as you can see, guys, these are 4 cases, okay. Would you please, Dr. Shreya, move your presentation? Put in mind what are you going to answer or cover in your answer, okay? Of course, you can add, okay, but you will need to answer the very important question, whether if this procedure or operation is suitable for this patient or not, okay? And if there is anything else that you would like to request or do for her, okay? And if this patient is going to be managed as outpatient or inpatient or in day unit, okay? And which case you will take first, okay? So this is the thing that you need to keep in mind. So now I'm looking to the board I have. This is the list that I will have today with my consultant, and I can see that there is patient presented. She's IVF. Always we ask ourselves why there is this pump in the case, okay? So I will say that this is special words that need your attention, okay? So IVF, that's mean high risk, okay? So 6 weeks ago, she had her LMP and she complained of pelvic pain and BV bleeding, and the scan is empty for DNC. Taking patient for DNC, actually, it's not appropriate at all, the DNC. We even take the patient in cases of emergency to E&E, okay, evacuation and curettage. So this is something that the examiner, okay, will be impressed if you explain that. And I would like you to say something very important. Whenever you say case of bleeding, you always say about the vitals, okay? Amount of bleeding and vitals. So if this patient is with profuse bleeding, that's why I guess it's here on the board for DNC, okay? Then this patient is an emergency case for me, right? If this patient turn out to be ectopic because of the pain mentioned here, then the operation will be laparotomy after stabilization. So very important, okay, that whenever you see bleeding, whether in the gynelast or in the labor ward prioritization, you mention about the vital signs and amount of bleeding. Okay, that's very important because the examiner, this is a safety point that the examiner is waiting for you to say it. Okay, this is very important. A second thing for the case, okay, that you're taking her, number 2, Joanna, you are taking her for a large pelvic mass, likely for ovarian cyst, and CA-125 had been done, and you can see that the age is 18. So this is inappropriate, okay, investigation or tumor marker for this age group. And the college, the RCGs, they like this case, so they can present it as a role play, they can present this case in the gynelast, or you can have it as a structured discussion solo case with the examiner. So CA-125, you need to comment on that. This is not appropriate investigation for this age group, okay, because of the germ cell tumors. So we need to ask for whether, okay, the tumor marker had been done or not. And if you can't see them on the left, so I need to say, okay, if this has been done and the case has been reviewed by the MDT and there is nothing worrying, okay, in her scan and result, then this case will be for a laparoscopic cystectomy rather than oophorectomy. Bear in mind her BMI, so we would consider another alternative entry technique, and for lean patient, we will consider Palmer's first or Hasson technique, and Palmer's should be mentioned first before the Hasson in lean patient. I will go to case number 3. Okay, so here in Irene, what is her condition? She is already now on the day morning of the operation, right? So what you need to do now, rather than if she had used another method of contraception, or she is aware of other method of contraception, long-term contraception, or suitability for her or not, okay, I would really want to know about her medical problems. Okay, so the echo here is the investigations that you need to ask. Okay, that's very important, and you will be awarding the mark for this and for the antibiotic and for the VTE thromboprophylaxis. Okay, and this is very, very important in this case. While in case number 4, okay, what we can see here, okay, the case has only large fibroid, she had been bleeding, she is already on the list. Okay, so you need to explain to the examiner whether you see that this case, okay, myomectomy will be suitable for her or not. So the examiner mainly waiting for you to say that, waiting for you to comment on the hemoglobin, okay, and waiting for you to ask whether she had already the GnRH or not, okay, to reduce the amount of bleeding. Taking the decision to remove a case from the gynae list, it's actually even if this case is a routine case, it actually will be like a very brave, okay, decision. So please explain it well before you say that. Why it's a very brave decision? Decision. That's because the patient usually waiting time in the NHS, even if it is a routine case, it can be 6 months, up to 6 months for an operation, for a routine operation. Okay, so once the patient in the hospital today, okay, considering cancellation of her procedure and reschedule her, that's mean, okay, you have to face the patient. Okay, you have to explain that to the patient that this will put you in trouble with her. So unless there is a very, very logical cause, okay, of your decision, please don't say that to the examiner. Suitability of the operation, mainly that you choose another operation. If the patient is for cancellation of procedure or we can delay the procedure, okay, please give some reason, like the case number 2. For the case number 2, I would say that having the tumor marker, the MDT, okay, and the scan, detailed scan result is a priority. Okay, this is a safety priority for the patient. So I will assure that this have been done, okay, and we are safe, and we are going to open up a case knowing what we are doing. Really, this is just an ovarian cyst, simple ovarian cyst, but large in size, then we will go for cystectomy, or this is a germ cell tumor, and in this case this is something else, and the case need to be rescheduled, okay, for appropriate expertise and appropriate place of doing this operation. So this is things that I need to explain to the examiner. Regarding the prioritization, case number 1, because she had bleeding, and as you can see, operation time, even if this is a case of just she had abortion, okay, miscarriage, sorry, and I want to do ENC, also she will be case number 1. If she is unstable, still she will be case number 1 for laparotomy. Case number 2, this is, I need to say plus or minus according to what has been done to her, okay, making sure that it is safe to go, okay, for this patient. Case number, the next case in the priority, okay, it's a day case, day procedure, right? So if you are going to do a laparoscopic sterilization, okay, so we don't expect that the operation time will be very long for this patient, so we will take it first. And the Anna, the last case, better, as Dr. Sabna and Dr. Shreya beautifully explained, very correct and brilliant, that hysterectomy will be a wise decision for this case. So you just suggest that to the examiner and ask, okay, whether if this has been, okay, explained to the patient or not. Okay, so this will be like changing the nature of the operation, but not sending her home. Okay, so this is the point I need to discuss. Thank you very much for the chance to explain that. Thank you very much, Dr. Shreya. You have done a beautiful presentation today, and I think all the points that you have said is really valid. Whatever came in my mind, you have really covered it. Okay, so I enjoyed myself listening to you today, dear, and I also learn from your feedback. Thank you.
Thank you, Dr. Abad. You have given me the opportunity, so thank you very much for that. Thank you, everybody.
Okay, so thank you guys, and hopefully my dear friends who are going to appear this February, all the best, and inshallah these sessions provide some, you know, enlightenment of the things that you can face in the exam. And I can say today with the role player, even the scenarios with the role player, Dr. Shreya, she was a wonderful role player, like the professional role player who are now, okay, organizing the exam. Okay, so yes, it was a very good question. Poses or expressions. Okay, this is what we expect to see from the role players. And for you, my dear friends, you have made this session really, really useful and fantastic session. Thank you very much.